A 50-year-old
हाँ
man, a 50-year-old man was
हाँ
admitted to this hospital because of acute pain in the left flank. The patient had
हाँ
been well with a history of Hodgkin's lymphoma 15 years earlier until approximately 6 a.m. on the day of admission when the pain in the left flank occurred while he was bicycling. The pain was localized without radiation and increased during the next 7 hours from the 3 to 8 on a scale of 0 to 10, with 10 indicating the most severe pain. He came to the emergency department of this hospital. At a routine annual visit 4 days before the admission, the patient reported feeling well. Examination revealed non-tender varicoceles and prostatic hypertrophy. The remainder of the examination was normal. A tetanus, diphtheria, pertussis vaccine booster was administered. During the next 4 nights, he noted mild nausea and temperature of 38.1 degrees Celsius without chills, which he attributed to the vaccination. First, 15 years earlier, a diagnosis of Hodgkin's lymphoma had been made, and the patient had received 6 courses of the doxorubicin, bleomycin, vinblastine, and dacarbazine, as well as radiation therapy and splenectomy. Hypothyroidism had developed after
हम्म,
treatment. He also had migraine, hyperlipidemia type 2A, biapical pulmonary fibrosis, and pulmonary sarcoidosis. A stress echocardiogram 21 months before admission showed normal left ventricular function at rest, a mildly thickened tricuspid aortic valve, mild aortic insufficiency with mild aortic root dilatation, and trivial regurgitation of the other valves. A stress echocardiogram was negative for the ischemia.
ए- एक सेकंड रुको.
Yes, sir. Yes.
एक फोन आ रहा है. हाँ.
So the stress echocardiogram was negative for the ischemia. Medications included calcium citrate, enteric-coated aspirin, simvastatin, levothyroxine, and 25 hydroxyvitamin D. And he had also received IM immunization against Haemophilus influenza, pneumococcus, and meningococcus in the past. He was married and worked in an office. He maintained a high fiber, low fat diet, and he exercised, drank alcohol in moderation, and did not smoke. His mother had breast cancer, and she and a maternal aunt had coronary artery disease. On examination, it's a case of
So see, basically, if we stop here, this
yes,
is a middle-aged guy
50 years
with left flank pain,
left line.
acute in
Yes,
onset,
acute.
and in comorbidities he has sarcoidosis,
This
apical fibrosis,
uh,
and
bifocal Hodgkin's lymphoma,
history of
Hodgkin's
Hodgkin's.
and pulmonary
So
sarcoidosis.
most huh. So most likely the apical fibrosis is secondary to what?
His chemotherapy, sir. He had received bleomycin
Which
during
one?
bleomycin, sir.
Yes. So most likely the bleomycin is causing the fibrosis.
Apical fibrosis.
Okay.
Yes.
Huh. And in sarcoidosis, are there any stages? What are the lung findings in sarcoid?
It's a bilateral hyaline lymphadenopathy and
What
with
else? sarcoidosis में fibrosis भी होता है ना, स्टेज 3 स्टेज 4 में.
Yes.
हाँ,
हाँ. So not just hilar adenopathy, there can be fibrosis also, na?
Yes.
So now what fibrosis is due to sarcoid and what is due to bleomycin, we can't say.
Okay.
We can't be sure.
Yes,
It's
sir.
possible that both are there.
Yes.
Okay. Classically, in sarcoid, you will have bilateral hilar adenopathy, which is non-necrotic. And in TB, you will have unilateral adenopathy with necrosis. This is how you differentiate sarcoid from TB. Okay.
Yes.
And in TB, you would not see fibrosis generally, at least in the acute and medium phase. Only in the long term, you may see some fibrosis at the apex. In sarcoid, you can have fibrosis in the mid zone and lower zone also. Okay.
Yes, sir.
So now acute flank pain can be many things. Renal colic, ureteric colic, colitis, some localized peritonitis. All of these are possible. Let's see आगे क्या पता चलता है. हाँ? बोलो.
On examination, the patient was alert and oriented and appeared uncomfortable. The temperature was 37.3 degrees Celsius. The blood pressure was 158/72. The pulse was 76 per minute. Respiratory rate 20 per minute. And the saturation was 100 normal. A holocystemic soft murmur grade 2/6 was heard at the apex with the radiation to the axilla, and a decrescendo systolic murmur grade 2/6 was also heard at the base, especially at the left upper sternal border. So एक तो MR है, mitral regurgitation जो holocystoma at the apex which is radiated to the axilla, तो वो MR है. And a decrescendo systolic murmur also was heard at the base, especially at the left upper sternal border. Pulmonary का कुछ नहीं.
So pulmonary basically is a ejection systolic murmur.
Ejection systolic murmur.
In the pulmonary area.
Yes, pulmonary area.
And holosystolic murmur in the mitral area. So both can be due to just flow, increased flow, tachycardia, hyperdynamic circulation, you know. Just few months back, the echo was normal.
Yes.
दूसरा ये होता है कि in long-standing fibrosis patients, there can be secondary pulmonary hypertension. That may cause, maybe, not sure. That may cause basically increased pulmonary pressure. पहले volume overload होता है, फिर बाद में there is a destruction of the microcirculation and that can be converted into pressure overload. That will be visible on the right-sided pressures, but you'll have elevated right-sided blood pressures. So that's another thing we can see in sarcoid. If there's long-standing extensive fibrosis, there may be pulmonary hypertension. Rarely there may be primary pulmonary hypertension also, even though there is no fibrosis. Either it can be completely primary or it may be seen in sarcoid without fibrosis also. समझा ना?
Yes, sir.
So let's see. आगे क्या?
Actually, the concept is like if there is a hypoxia due to any this lungs causes, it will cause the pulmonary vasoconstriction leading to the pulmonary hypertension. So this can be a reason, like fibrosis occurring to pulmonary function is impaired. So there can be hypoxia leading to the pulmonary vasoconstriction.
So even without too much hypoxia, the fibrosis will increase the resistance of the lung. No? Lung compliance comes down. I think that by itself will affect the microcirculation, which is connected to the pulmonary artery, leading to elevated pressures. So you don't need very high hypoxia for a prolonged period for any pulmonary hypertension. Okay?
Yes.
Okay. So what is the new classification of pulmonary hypertension?
New classification.
And in which class of pulmonary hypertension will pulmonary vasodilators be helpful? And in which class they can be harmful or not to be given? What are the causes of pulmonary hypertension that you know?
Primary and secondary, sir. So primary and secondary, it can be due to connective tissue disorders or
Hmm.
So core pulmonary will cause pulmonary hypertension. Core pulmonary. Because
Core
right.
pulmonale is right heart failure, secondary to some lung problem. It is not a cause, it is a result. It is a result of pulmonary hypertension.
Yes, okay.
So basically, read up. This is a new thing. You have to know this. Huh? So primary pulmonary hypertension में there is elevated pulmonary artery pressures. We don't know the exact reason. It is idiopathic. तो उसमें pulmonary vasodilators help to reduce the pulmonary pressures, okay, and reduce the chances of core pulmonale. So pulmonary vasodilators, let's get into that later. Okay. So secondary pulmonary hypertension can be due to many reasons. And those are classified into various classes. Okay. So COPD is one. Okay. Pulmonary fibrosis is another.
Yes.
Then chronic pulmonary thromboembolism is another.
Yeah.
And lastly, left heart failure with volume overload is another.
Yes.
Okay. So in all other classes, actually, if you give pulmonary vasodilators, you will cause harm. Can you tell me why and how?
So it can lead to left ventricular dysfunction. No.
See, what is happening in COPD? The mechanism of hypoxia in COPD is what?
The CO2 retention.
Hypoxia क्यों होता है COPD patient में? We have discussed this in the previous lectures, yeah? तुम लोग सब भूल जाते हो. VQ mismatch, na?
Yes. Yeah.
VQ mismatch. So some areas of the alveoli are well ventilated. Other areas are not so well ventilated. And some are well perfused, others are not so well perfused. So this kind of VQ matching is attempted by the lung. Barabar. But when you give pulmonary vasodilator, you are increasing perfusion blanket everywhere. You end up increasing the perfusion to even poorly ventilated alveoli.
Yes.
So VQ mismatch increases. बराबर जो अमित पहले बोला ना देयर इज अ हाइपोक्सिक पल्मोनरी वेजोकंस्ट्रिक्शन उसका रीजन यही है कि जो एरियाज अच्छे से वेंटिलेट नहीं हो रहे जहाँ पे पानी भरा हुआ है या इन्फ्लेमेशन भरा हुआ है वहां पे ब्लड नहीं जाना मांगता है नहीं तो हाइपोक्सिया बढ़ेगा बराबर सो द लंग डज दिस वाया वेजोकंस्ट्रिक्शन बट व्हेन यू गिव वेजोडाइलेटर dilates everything.
Yes.
So it increases the flow to the poorly ventilated areas and causes worsening. Barabar. Same thing happens in the fibrosis patient and same thing happens in the left heart failure patient. So in the left heart failure patient, If you give pulmonary vasodilator, again you are causing more harm.
More perfusion.
So the pulmonary vasodilators are to be used only in the class 1 primary pulmonary hypertension.
Yes.
In most other reasons, we have to avoid it.
Yes.
Barabar.
Right.
So now, what are the pulmonary vasodilators that you know about?
Sildenafil and
PDE5
phosphodiesterase inhibitors. Phosphodiesterase 5 inhibitors.
वही है ना, सिल्डेनाफिल क्या है?
वही sildenafil
Sildenafil and tadalafil.
हाँ, और भी एक है ना ग्रुप,
prostacyclin analogs.
So endothelin receptor antagonist.
नहीं, वो
हाँ,
vasodilator.
तो नाम बोल।
Ambrisartan,
Bosentan.
हाँ, बोसेंटन है ना, बोसेंटन and all that.
Bosentan.
हाँ, so those can also be given for pulmonary vasodilation. Okay, ठीक है। तो ये कहाँ से आया था अपना टॉपिक?
Sir, the patient had pulmonary fibrosis and pulmonary sarcoidosis.
Yeah, correct. ठीक है, okay, आगे बढ़ो। हाँ, understood the concept ना? I will
Understood.
send you a link to some good data on this also. हाँ?
Yes, sir.
बोलो, आगे बढ़ो। हाँ।
The abdomen was non-distended with normal bowel sounds and moderate tenderness to palpation in the left flank below the costophrenic angle without guarding. Examination for Murphy's sign was negative. The remainder of the examination was normal. The blood levels of the electrolytes, calcium, phosphorus, glucose, total protein, albumin, globulin, amylase, and lipase were normal, as were the hematocrit and hemoglobin platelet count. And urinalysis test of coagulation, renal function, and liver function were negative. So other tests will be showing the WBC count were 11,400 on admission. Out of which neutrophils were 76, lymphocytes was 14, and D-dimer was raised. It is 663. ESR was raised. It is 19. CRP was 59.7. Lipoprotein A was 11. Cultures of the blood and urine were obtained. An electrocardiogram showed sinus rhythm at a rate of 78 beats per minute with probable left ventricular hypertrophy. IV fluids, ondansetron, narcotic analgesics were administered as were the patient's usual doses of the levothyroxine and simvastatin. There was symptomatic improvement. CT scan of the abdomen and pelvis after the administration of oral and IV contrast material showed layered hyperdense material in the gallbladder, a feature suggestive of gallstones, and a focal wedge-shaped defect in the left inferolateral kidney with patent renal arteries and veins. CT thorax performed according to the protocol of the assessment of the pulmonary embolism revealed bilateral posteromedial fibrosis and pulmonary nodules 2 to 3 mm in diameter in the right lung, which was stable as compared with the previous studies. There was no evidence of any filtering defects in the pulmonary arteries or of mediastinal hilar or axillary lymphadenopathy. 7 hours after presentation, the patient's temperature rose to 37.8 degrees Celsius. He was admitted to the hospital. Diagnostic test were
So now you stop. Okay, so now in the CT, they have described something that sounds like a infarct, which seems like fresh infarct, and that may be the one responsible for the pain. Barabar. So now what is your diagnosis at this point?
Acute renal infarct. Probably some likely can be ischemic etiology or
thrombotic phenomenon which might have caused renal infarct.
Why is he going to get thrombosis? Spontaneous thrombosis क्यों होएगा इसको?
So dyslipidemia, spontaneous dyslipidemia.
Thrombosis तो ये रहेगा arterial thrombosis.
Dyslipidemia is risk factor ना?
History है Hodgkin's lymphoma, but that should not.
Cytopenia.
But this patient also has a new onset murmur, sir. So possibly
Yes.
embolic phenomenon because of infective endocarditis. He also had fever on admission.
Exactly. Exactly. So see, first you have to think, okay, history of Hodgkin's is there. If there is a recurrence of the tumor, then there may be a tumor embolus. Okay. Second thing you have to understand is that it's a fresh onset murmur in the heart and LVH, which was normal just 1 month back or 4 5 days back or 4 5 weeks back. I don't remember.
21 months.
Barabar. So fresh. So fresh onset murmur with renal infarct means there may have been a cardioembolic septic embolus due to endocarditis. Barabar.
Yes.
So now that is the one that is fitting best actually. Other thing is that then we have to think, why did he get endocarditis?
Yes, sir.
बराबर. तो इसमें अभी फिर अपन वो हिस्ट्री में जाएंगे. Has he undergone recent dental procedure, any colonoscopy, anything like that, or has the patient been on steroids for the pulmonary fibrosis or the sarcoid? So that may predispose him to infections. बराबर.
Yes, sir.
So right now, working diagnosis, clinical diagnosis is endocarditis. Second diagnosis is query recurrence of Hodgkin's with a bland embolus to the kidney.
Yes, sir.
But endocarditis seems more likely. Barabar. So you have to correlate everything, na? To see everything together. Barabar.
Yes.
Now another rare thing that's possible, rarely, maybe something like melioidosis, which can cause lung infection with renal infarcts. Rare, possible. It may cause renal abscesses also. Anyway, आगे बढ़ो. हाँ?
Sir, can any vasculitis can also present with thrombosis, no?
Bleeding, no?
Possible, but the heart findings will not be explained adequately by the vasculitis. Possible, but let's see.
Yes,
But
sir.
if he has been on steroids for the for fibrosis and sarcoid, that reduces the chances
Yes, sir.
of vasculitis.
Yes.
बढ़ो आगे बढ़ो.
So there are differential diagnosis next. There's a ischemia, and next is
अभी ये उन्होंने और कुछ ऐसा नहीं बोला. A diagnostic test was performed. ऐसा कुछ नहीं बोला.
was diagnostic test were performed. इतना लिखा
आगे रहेगा.
laboratory test है. laboratory test मैंने आपको बताया सर. और फिर CT scan.
So the lab test.
11,000.
Yes, sir.
11,400.
11,000 काउंट है.
Yes, sir.
क्रिएटिनिन कितना है?
क्रिएटिनिन किया नहीं दिया है. CT scan तो पता है. एकोकार्डियोग्राफी. एको पे एकोकार्डियोग्राफी.
एको में तो
aortic insufficiency था. The moderate to centrally directed aortic insufficiency without evidence of any aortic root abscess or paravalvular leak.
So it's a fresh onset aortic regurg.
Yes, sir.
So it can happen in endocarditis, and means the embolus or the vegetation may have already gone through the kidney, so the echo may not show vegetation. जब ये embolic phenomenon हो गया है ना, तो echo can come negative.
Negative, yes.
In endocarditis. Okay.
Next is a fever.
CRP, ESR ज्यादा रहेगा ना. ESR, CRP will be high.
ESR 19 था. CRP
Urine routine में.
Urine routine नहीं.
Urine routine में कुछ
normal they have said.
RBC वगैरह आएंगे शायद. ठीक है, आगे बढ़ो.
और सर दूसरा डिफरेंशियल डायग्नोसिस फीवर इन अ एसिक्लिनिक पेशेंट. Causes can be infections, every infections जो भी streptococcus pneumonia, H influenza, पर उसने वैक्सीन लिया था ऑलरेडी सर. और दूसरा ये एंडोकार्डाइटिस और रीनल इन्फेक्शन.
करेक्ट.
फिर causes of renal infarction दिया है. Causes will be thromboembolic cause. from the heart or aorta, in situ thrombosis, renal artery occlusion from the aortic dissection, spontaneous or iatrogenic renal artery dissection, fibromuscular dysplasia, segmental arterial medullosis, polyarteritis nodosa, complication of the antiphospholipid syndrome, and cocaine use. Clinical diagnosis, anatomical diagnosis with thromboembolic renal infarction due to endocarditis in an asplenic patient. And clinical diagnosis, endocarditis complicated by an embolic event in the kidney.
Then blood cultures.
Pathological discussion of the two sets of blood cultures were received by the microbiological laboratory on the day of admission, which showed a gram stain showed the gram positive cocci and cocobacillary forms are present.
बोलो सुन रहा हूँ.
Gram positive cocci were present. और viridans आया था sir. This culture, the organism was identified as Streptococcus mutans, a member of a viridans group Streptococci. And Streptococcal species are the most common cause of the native well endocarditis in adult patient. 15 sets of blood cultures were obtained during the hospital course.
15 sets.
Yes, and out of which 11 out of the first 14 grow
Streptococcus mutants.
During his whole
Phlebotomy
hospital course. During his whole hospital course, 15 sets were taken.
The high grade
protocol hai. After one culture comes positive, na, as per the guideline, they have to repeat every 2-3 days or every day till you get a negative.
Okay.
और ऐसा prognostic marker है ऐसा कि 3 दिन तुमने दिया, तीनों दिन positive आया तो prognosis is worse.
Okay.
We don't end up doing all that because it becomes expensive and doesn't change the treatment. We do after 3-4 days usually minimum. Anyway, बोलो. हाँ फिर.
The bacteremia was suggestive of an endovascular source of the infection, and in conjunction with the clinical and echocardiographic findings, was consistent with the bacterial endocarditis and septic embolism to the kidney. The final blood culture came positive, was received on the 5th hospital day, and was reported positive on the 7th hospital day. In addition to the growing Streptococcus mutans, this final positive culture also grew with MRSA. It was presumed that the MRSA infection was acquired during the hospitalization admission. All subsequent blood cultures were negative.
So how will you treat this patient? Forget the MRSA. For the strep mutants, how will you treat? Ceftriaxone की penicillin. Ceftriaxone की penicillin.
Ceftriaxone with Ceftriaxone, sir.
अरे तुम MIC तो देखो भाई. Treatment depends on the penicillin MIC.
Yes.
See, practically we'll give a ceftriaxone because penicillin मिलता नहीं है. But theoretical answer is you have to look at the penicillin MIC. because 0.12 या ऐसा कुछ है, less than 0.12 रहेगा तो you can give penicillin. Dose will be
1.2 million.
20 lakh units IV 6 hourly या 4 hourly ऐसा कुछ चेक कर लो.
Yes sir.
एंडोकार्डाइटिस डोज पढ़ लो, ये सब पूछेंगे आप.
Yes sir.
सो इसमें क्या बोला है उन्होंने?
फिर फॉलोअप
लिखा है
में
पेनिसिलिन एमआईसी एंड क्या दिया, कुछ लिखा है?
फॉलोअप नहीं, इसे लिखा नहीं उन्होंने, सिर्फ एमआरएस से डायग्नोस हुआ. And then the patient was treated for the streptococcal endocarditis and bacteremia with penicillin while in the hospital. He then switched his antibacterial therapy to ceftriaxone, which is easier to administer on an outpatient basis. And he completed
कितना दिन दिया?
completed a 4-week course of the ceftriaxone. For first 2
हाँ.
weeks, he was also treated with the vancomycin and gentamicin for MRSA bacteremia. A follow-up thoracic echocardiogram obtained 3 months later showed persistent mobile density on the aortic valve. Although it appeared improved, the patient is now doing well. So what can we learn from the physical examination from the cardiac ultrasound study? The patient was said to have 2 murmurs. One was consistent with the aortic stenosis, and the other was more consistent with the mitral regurgitation. That's it. Right side.
So actually lower left sternal border bola na, so that's not pulmonary area.
That will be pulmonary.
That is
किया है वो. I suspect the clinical environment makes
upper
a huge. I suspect the clinical
aortic area will be upper left sternal border ना,
right side होता है ना
कि pulmonary.
upper left aortic is upper.
तो बहुत ग्रॉस है यार, मैं भी भूल गया हूँ.
नहीं सर राइट
तुम पढ़ के बताओ.
राइट सेकंड इंटरकोस्टल स्पेस में होता है.
So aortic is right sternal border. Pulmonary is left sternal border.
Yes, left side, right. Second intercostal space, right.
Pulmonary left.
तो उन्होंने क्लियर किया है शायद, बोला था क्या.
So what
anyway, ठीक है, फिर क्या एंड में और कुछ है उनका?
So they said कि the systolic flow murmur which they heard was due
flow
to
murmur.
probably a flow murmur secondary to an increased
fever or
as you said.
tachycardia. Secondary to fever or
Aortic regurgitation. So the mitral murmur is probably due to the aortic regurgitation. वो तो मालूम है ना, तो grade 2/6 था. एक सेकेंड ना, एक फोन आया, रुको.
Six minutes.
Was